All right. Hi, everyone, and welcome to STAT's virtual event. The 340B drug discount program is at a crossroads. What's next? Thanks for joining us. I'm Rachel Kors, Washington correspondent here at STAT. And before we get started, a few quick housekeeping items. At the bottom of your screen, you should see several icons. Use the chat feature to chat amongst yourselves or to send a message directly to the STAT team, which appears as STAT events. Don't put your questions for us in that chat. If you do have a question that you would like to ask the panelists during the event, please use the Q&A feature to type your question and we'll try to answer it live. In the Q&A window, you should also be able to see the questions that other attendees have asked and upvote questions that you would most like to see answered. We'll be taking questions throughout the chat, so please don't wait until the end to submit your questions. This is what part of makes these events fun. And thanks again to you all for being here. Here to join me for the first editorial portion of today's event, I'd like to welcome our first speaker, Robert Chero, who is a senior chair of healthcare and FDA practice at Greenberg Traurig. He served as a general counsel for the U.S. Department of Health and Human Services during the Trump administration. Before that, he held several posts as an attorney at HHS, as the deputy chief counsel for the Reagan-Bush campaign, and he's also taught as a law professor. And please note that any views expressed by Bob are his own and are not the opinions of clients of his firm. Thanks so much for joining me today, Bob.
My pleasure.
All right, so just for an introduction, for those of you in the audience who aren't huge 340B wonks, I wanted to start off with a very brief explanation of the program. The 340B drug discount program was created by Congress in 1992 and allows healthcare providers, those that serve a certain proportion of low-income patients, children's hospitals, rural hospitals, and health centers, to buy drugs at discounted rates from pharmaceutical companies. This program has grown much larger in recent years. It's been a hot topic of conversation on Capitol Hill and in the regulatory space. And it's going to have an especially high-profile stage this year before the Supreme Court, which is, I think, what the first topic that I'd like to chat with Bob about, because I think you have so much experience in the law, so much experience with this program. Can you just give us a preview of what we're going to see in oral arguments before kind of the Supreme Court on this 340B case?
It started out as a typical, very boring reimbursement case in the district court. At issue was a rule issued by the department which cut back the amount of payment made for outpatient drugs in outpatient departments from 106% times the average sales price, which would be the normal Part B payment, to, I believe, 28.5% less. So 77.5% of the average sales price. The American Hospital Association, after having successfully or unsuccessfully, depending on how you look at it, presented claims, filed suit in the district court. The district court held that a provision of the law that ordinarily precluded administrative and judicial review did not apply here because the agency, his interpretation was beyond the scope of the statutory provision, which is in 1833T, and went on to hold that the agency's interpretation was in fact not justified. The department appealed to the DC Circuit, and in the summer, the DC Circuit held that number one, it did have jurisdiction, that the agency's view that the court lacked jurisdiction, in other words, judicial review was precluded, was not well-founded. Its view was slightly different than the district court. It held that the provision did not really apply to this subsection, or actually not a subsection so much as a paragraph of the act, and went on to hold that the provision was ambiguous, and as a result of that ambiguity, the department's or CMS's view was reasonable, and under Chevron, it accorded deference. There was a dissenting opinion that held that you need not reach Chevron 2, that this case would be disposed of in what's called Chevron 1, which merely is a statement that the law is in fact not ambiguous and it must be interpreted to preclude the agency from doing what it did. Okay. And the original petition filed by the American Hospital Association asked the court to decide one issue, and that is whether the lower court erred The government responded to the cert petition with a second issue, namely, does the court have jurisdiction? And there is a third issue hiding in the wings. This is a case where you have two existential issues around a rather mundane reimbursement issue. And the two existential issues are, number one, by existential, I mean it could affect all providers. Number one, how is the no judicial review provision going to be interpreted by the court, since they're close to, I think, 30 of those provisions in the Social Security Act? And second, is the court going to do anything with respect to Chevron deference, which was raised by the petitioner, the American Hospital Association, as a 4-page aspect of its brief, portion of its brief, but has drawn a lot of attention from the various amici. There have been 9 amici submitted in support of the AHA, I should say 8 support AHA, 1 in support of neither party, and that was an extraordinarily well-written brief by the chamber, Paul Clement, basically asking the court to make certain that the lower courts apply Chevron and apply it with appropriate guidelines. And so that's the state of play. The case has not been fully briefed. The government's brief will not be filed until October, and amici in support of the government will not be filed until October. Then there'll be a reply set of briefs. The case has not been scheduled for oral argument. I would expect oral argument sometime in early 2022 would be my guess. And as a general rule, the court decides cases like this, i.e. that are not extraordinarily controversial, within 100 days after oral argument, give or take.
Thanks so much for that summary. we packed in a lot there. One phrase that you kept using that I don't know that our audience will be like entirely familiar with, or maybe could use a refresher, would be kind of what Chevron deference is. And, really it kind of dictates the relationship between kind of the judiciary versus the executive branch. Like, could you explain a little bit how that has to do with this drug discount program?
It is a loaded phrase. It is actually a test originally developed by Ken Starr when he was sitting on the DC Circuit, that was largely adopted and crafted by the Supreme Court in the Chevron case. And it basically tells lower courts, there are 2 steps when you are presented with a regulation. Step number 1 is to decide whether the regulation is actually authorized by the statute. Does it fit within the ambit of the statute? And if your answer is yes, that's the end of it. If your answer is no, that's the end of it. If after exhausting all of the tools in your quiver, you conclude that the provision is ambiguous, and that's important, exhausting all the tools in your quiver for statutory interpretation, the provision is ambiguous, then you look at the interpretation of the agency and you decide whether that's reasonable, and you defer to reasonable interpretations of the agency, which is a way of saying that if you reach Chevron step 2, the odds of the agency prevailing are significant.
Okay, thanks so much for that primer, and we'll look forward to hearing from you too, once we do advance to those arguments in a couple months. So one other issue that I wanted to touch on is kind of the discourse around contract pharmacies. So there have been disputes for several months, almost a year now, I guess, more than a year, about how providers who receive 340B discounts are allowed to distribute their drugs, whether they should, distribute the drugs through on-site pharmacies, like a pharmacy that you would go to in a clinic or a hospital, or whether they can contract with other pharmacies to, make those drugs, more convenient, but also more widespread. So that's been a flashpoint. There have been letters back and forth. There's been a lot of conflict between drug makers and healthcare providers on this issue. And I think, Bob, a lot of people on this call might know you from an opinion that you wrote on this issue when you were general counsel at HHS. And I guess, first of all, I just wanted to give you a little bit of time to explain how you approached this issue. It obviously is very controversial how did you go into this question that clearly has a lot of money and a lot of patient access issues at stake?
I understood the policy concerns, and I received letters from both the pharmaceutical industry as well as from various 340B provider groups, as well as from hospitals in the 340B program, asking me this question. And we received enough letters where I thought it was appropriate for the office to opine. And when I was being considered for this position during my Senate confirmation hearing, I was specifically discussing with the senators how I would decide controversial questions of law. And I said I would decide them as if I were a district court judge. And basically, I would sit down and just review the law and review the positions on both sides. And that's what I did here. I looked at the provisions of the statute. To me, they were fairly straightforward and fairly clear. And that absent any words that I may have missed, once a covered entity is a qualified covered entity, they must be offered the drug at no more than the ceiling price. There's no ifs, ands, buts, or whys about it. And as long as they take title, they've satisfied the 340B fundamental criterion on the front end. Now, there can be problems on the back end, and certainly the drug manufacturers have the right to audit or request an audit and question whether there has been diversion. But on the front end, the flexibility is non-existent.
Excellent. Yeah, thanks for that rundown of your thinking. That opinion, caused quite a bit of controversy in the 340B world. And, I think the current administration did end up withdrawing that letter. It was involved in some litigation. I guess I just wanted to give you an opportunity to reflect. Do you still think do you still stand by the letter, after, everything that's happened after?
I still believe the legal analysis is correct. And I would issue it again. I found myself my last week in office as being a defendant in four pieces of litigation. It's always nice to see your name in the caption.
Absolutely. So there's one audience question that is kind of related that I wanted to run by you, and that's whether you feel the Supreme Court decision in the kind of 340B Chevron case that we chatted about earlier could affect the outcome of this contract pharmacy litigation that's ongoing?
I don't think so.
Don't think so. Okay.
It's not teed up for the court. It's not
Okay.
before the court.
Excellent. Yeah, there's so many kind of intertwining issues. It's hard to keep them straight sometimes. Okay, so I think also wanted to give you a chat about one of these, other intertwining issues, which is a dispute resolution process that, I think it was the Affordable Care Act that said, we need to set up some sort of mechanism for drug makers and healthcare providers to work out their issues through, a regulatory process. And obviously it took about 10 years to issue those regulations. They've been held up in court after the Trump administration did, issue those, issue the rulemaking on kind of that, creating that framework. So I was curious, do you think this could, really make a difference in the program and create an avenue so, disputes could be resolved before going to court? How do you think this could impact the program?
Yeah, well, obviously, there have been court decisions over the past, I would say, 10 years that have limited the ability of the parties to actually litigate in court against one another. So this mechanism is set up. It's rather unusual because usually when you have an administrative dispute resolution process, it's between the government or an agency and a private party. Here you have a dispute resolution system between two private parties, very much like what is at the PTAB, which is the PTO, Patent and Trademark Appeals Board. And I think that if it goes into, if it is ultimately implemented and folks are actually appointed to it, and there needs to be one slight tinker with it in light of a Supreme Court decision called Arthur X that came down after the rule issued. But once there's a slight tweak to it, it should go into effect and the parties can litigate their little heads off. Put a lot of lawyers, kids through college that way.
Excellent. Yes, that'll just be a whole nother, course to follow for kind of how this program will be shaped in the coming years. There's also one other issue from your tenure that I wanted to ask about, and that is the Trump administration's policy on EpiPens and insulin in relation to 340B discounts. Kind of the policy was generally that, if community health centers, which receive some federal funding, are legally required to reinvest, their profits in patient care. If they aren't passing these discounts directly to patients at the pharmacy counter for these drugs, then their federal funding would be in jeopardy. So I just wanted to ask you, why this program, this policy was targeted at community health centers versus also including some of the bigger 340B covered entities like hospitals?
Yeah, it's a valid question, but it's unfortunately one I can't go into.
All right. Can you give us any color on whether that was an HHS decision, something that ran through your office, or
it certainly was not. It was not my decision. Came from elsewhere.
Okay, we'll have to leave it at that, but just want to touch on that. And also, I think something that I really wanted to work on kind of in this panel is talking about, solutions and, moving forward, how we can, improve the program and potentially make it more workable. So I'm just curious how you, if you have any recommendations after thinking about this for a long time, or, have any insight for our audience on kind of where the program is headed and what they should be watching for.
Yeah, I guess one of the unintended consequences really has nothing to do with drug pricing. It only has to do indirectly. And it's been an incentive for hospitals that are located, for example, downtown, to buy clinics and practices that are located in the suburbs. Because then those clinics, if they're part of the same cost report, can in fact become 340B entities. And so you can have a Hollywood producer buying a drug at Rodeo Drive, and that guy is a 340B patient. And that strikes a lot of people as being inherently unfair and inconsistent with the purpose. But obviously it has led to the acquisition of hospital clinics by hospitals, an amalgamation of hospitals.
Absolutely. Yeah, the program is one where, we don't see the direct, discount to patient at the pharmacy counter. It's kind of a broader benefit to the healthcare providers that, certainly may see benefits to patients at the pharmacy counter or in, other areas. So it is an unusual program in that sense. And I think I think we're almost at time. There's one quick clarification we had from an audience question. I just wanted to give you an opportunity to address, and that's with the alternative dispute resolution process we talked about. You said there's one tweak needed. Can you clarify what that tweak is?
Yeah, the tweak is that when the rule was originally issued, the 3-member panel would make the final agency determination. And the Supreme Court in the Arthrex decision indicated that there had to be what we call a PAS, an officer, someone appointed by the president with the advice and consent of the Senate, who makes that final determination or is available to make that final determination. Okay. So that's the tweak.
Thanks so much for clearing that up. Hopefully that's helpful. And I think that's all the time we have today, Bob. So thank you so much for
having me,
joining, for your insight. It's so valuable.
Take care.
Yes, of course. Okay. So I think we're going to transition to our stakeholder panel now. And here to join me for the second portion, I'd like to welcome Ted O'Con, who's the Executive Director of the Community Oncology Alliance. Welcome, Ted. We have Maureen Testoni, who's President and Chief Executive Officer at 340B Health. And then we have Visharia Tutson, who's the Director of Regulatory Affairs at the National Association of Community Health Centers. All right, welcome. And our final guest is Sylvia Yu, who's the Senior Counsel for Federal Programs at Pharma. Thank you all for taking the time to join the discussion today. So I think everybody's kind of coming from different perspectives this afternoon. So I just wanted to start off with a pretty straightforward question and ask each of you kind of what you feel the goal of the 340B program should be. So I think, Fisheria, do you want to start it off and we can go from there?
Yeah, sure. Thank you for having me. From the health center perspective, the goal and the intent of the 340B program is to stretch scarce federal resources. Specifically for health centers, 83% of our patients are usually on Medicaid or have no insurance at all. And so for those patients that also need access to affordable medications, they also need access to comprehensive health care that's respectable, but also near them. And so this program allows health centers to keep their doors open, to the ability to be able to provide specialty care, to help those patients with other things, other issues that address social determinants of health. And so having this comprehensive approach for patients and people who are medically underserved areas is really important. And we're grateful for the 340B program that has allowed health centers to really maximize their funding, but also reach as many patients as possible that really need the help.
Excellent. And there's one other point I just wanted to make about community health centers, that there is a legal requirement to reinvest.
Right. So we have a legal requirement under the health center mission, under statutory regulations as well, to reinvest every penny that we have generate in savings back into medical care. So that's how we use the 340B program. Health centers really, if we lost those savings, would probably have to lay off staff, maybe close their behavioral health departments, not be able to provide the HIV specialty care that we do. So it's really important that we use those savings to help those patients that don't have insurance, those patients who would not be able to afford the comprehensive medical services they deserve to have.
Okay, thanks so much. Sylvia, do you want to go next?
Thanks, Rachel, for inviting me to join the panel today. We think this is a really important topic. Pharma sees the purpose of the 340B program as such to help ensure that covered entities get manufacturer discounts, to allow them to have access to affordable discounted medicines that should be used to help low-income patients. When the program was created almost 3 decades ago, it was really created to help vulnerable patients. But over the decades, it's less and less clear that patients are benefiting today. The program has grown so big, is now the second largest federal prescription drug program behind Medicare Part D. But with that growth, we haven't seen also the same level of growth in terms of care for vulnerable patients. This is really, it's disconcerting. And it is because our companies are funding this program entirely. It is funded entirely 100% through manufacturer discounts. And manufacturers are paying tens of billions of dollars every year to covered entities. But because of the lack of transparency, we don't have a way of knowing, where these discounts are going, how they're being used, or even if they're being used to help patients afford their medicines. But we do think there are ways that the program can be fixed, and we're here to, I guess, talk a little bit about some solutions as well.
Excellent. Maureen, would you like to go next?
Great, yeah, thank you. And thanks for having me. So with 340B Health, we represent hospitals that participate in 340B, and I can tell you that the 340B program is just critical to their ability to provide care to their low-income patients and to their patients that live in isolated rural areas. The benefit of 340B is used to help patients in many ways. Certainly helping them afford drugs is one way of doing it, but for a hospital, care in a hospital is so expensive. We provide so many services, very expensive services to people, like cancer care, like diabetes care, medication management. Those are all services that are funded in part by 340B for the safety net hospitals. We also do translation services, transportation services. We provide trauma care, burn center care. We're much more likely to provide those services. And you can really look at hospitals to see what they're doing with 340B, because hospitals are required by law to report every dime that they take in and every dime that they spend in Medicare cost reports that they submit every year to the government. And they're also required to report a lot of that information on their tax forms. And because we are all, you have to be nonprofit or public institutions to be in 340B, those are all available to the public to review. So there's a lot of information out there about how hospitals use 340B. We provide 60% of the uncompensated and unreimbursed care that hospitals provide, and we also are responsible for 75% of the very expensive inpatient care to Medicaid, just as some examples.
Okay, thanks so much for that, Maureen. And Ted, would you like to round us out for this question?
Yeah, thanks, Rachel. And excuse me, thanks for having me today. I think the bottom line is this is a program that when you look at the most recent stats, that this is a $38 billion program in terms of sales of 340B drugs. This should be a program that should clearly help individuals in need. In this country, if you look at the number of uninsured individuals, the number of individuals who are insured but can't afford, don't have secondary insurance and can't afford drugs, this is so key. Back in 1990, when Medicaid best price was created, 2 years later, Congress panicked and said that basically all those discounts that pharma voluntarily gave away now won't happen because of Medicaid best price. So they wrote in 340B section basically into the law at the time that basically required manufacturers to participate in Medicaid to give these discounts. And I think part of the problem with the program is that it went originally to a handful of safety net providers and is really morphed, I would even say mutated, into a program that's unrecognizable from its started. And my biggest problem with the program, and by the way, I am a big supporter of 340B. I've been accused, COA has been accused of not supporting 340B. It is absolutely critical. But when you look at the grantees, when you look at the federal grantees, Community Health Center, Ryan White, AIDS clinics, hemophilia, all of that, there's a level of transparency and accountability that doesn't exist on the hospital side. And frankly, it's a black hole that regardless of all the reporting that's done, when the dollars go into a hospital, and I'm literally looking at a report starting with the largest 340B user that makes over $300 million a year in 340B discounts. And the bottom line is you can't tell that patient in need is getting it. We have clinics that have basically sent patients over to 340B hospitals, and they're under no requirement to take those patients. So the biggest problem is that we need to guarantee and ensure there's a level of transparency and accountability, like Visheri has said, basically with the community health centers, that these discounts go to helping patients in need that can't afford their drugs.
All right. Well, thanks for kind of that scene setting so we kind of know where everyone's coming from. I think the first issue that I'd like to talk about a little bit is the contract pharmacy issue. And I think I'd like to provide an opportunity for, I think we'll go with Visharia first to just kind of explain what contract pharmacies, what services they offer to your members and the patients who visit those clinics.
Yeah, thank you for that. Contract pharmacies are essential for community health centers. When you think about where we are located, sometimes a health center is the closest healthcare provider within 30 minutes, an hour, or even longer. And so for us, the contract pharmacy model helps our patients have one less day where they maybe have to take 3 buses to get the care they need or something that's vital for their healthcare. So most of our health centers would not be able to participate in the 340B program if it wasn't for contract pharmacies. And so when we talk about equitable access and we talk about affordable access to care, that includes being able to pick up your medications near your home. So if that means that our health centers are contracting with pharmacies to allow our patients, instead of taking multiple buses to go back to the health center, but they're able to go to a pharmacy near their job or near where their kids' daycare is. That's the goal for us in contract pharmacies. And it's very important that even though we are contracting with pharmacies, the health center mission is still staying true. Our patients are using those services to be able to get the medications that they need and that they were already having access to. It just is now in a better model. And so we are actively monitoring the contract pharmacy issue. As we know, it's in a lot of litigation right now, and that's at the crux of our ADR petition, is to have the 340B statute. Our interpretation, and what we believe also the administration's interpretation has been, is that contract pharmacies are a part of the 340B program. And so it's vital to us. And as we reinvest our care, we wish that every single health center could have an in-house pharmacy, but unfortunately that is not the reality of the situation of a lot of our health centers. And so without contract pharmacy access, it would be detrimental to community health centers.
Okay, Maureen, would you like to add anything on for your members and just kind of the advantages of kind of the option of having contract pharmacy services for your members as well?
Sure. So I agree with everything that Visharia just said. Well put, Visharia. And I would add, 340B contract pharmacies have been part of 340B almost since the inception of the program. And the reason is because a lot of people obtain their drugs at these at pharmacies. And so to have a 340B program that says, we are going to make sure that you are getting some financial help to stretch your resources, we're going to make sure of that, safety net providers, but we're not going to let this program really apply to all of these drugs that are filled outside of your premises, just doesn't really make sense. And so it's been part of it from the beginning. And as Bob Charo just said, there really isn't any wiggle room in the statute, and the administration has made very clear that this is part of the law and it's something that they expect drug companies to follow. I think it's important to note that of the 600 drug companies in 340B, there's only a very small number that are not following it. So 8 total. So I think that those are important things to keep in mind when thinking about contract pharmacy and this issue that's going on right now.
Thanks, Maureen. And Sylvia, I think Maureen just mentioned, the drug makers who, have some concerns about this program have, decided they're not going to engage with contract pharmacies, have, maybe set some conditions, some data collection, requests. So I'm just curious if you could kind of detail some of the concerns your members have about contract pharmacies and how they're being used now.
Sure. So I should probably say from the onset that pharma is a trade association, and because of that, I'm not able to comment on individual company actions and practices. Each company took an independent action, and many of them have released information to the public about exactly what those policies look like. I believe some of them have exempted grantees in some cases, but I'd refer you to those, press releases to get, specific individual company action information, as well as their reasoning for that. But I don't think it's a surprise to hear that pharma's been on record raising concerns about the growth of the contract pharmacy program, particularly over the last few years. As a legal matter, I'll just say that the concept of contract pharmacies only comes from HRSA's sub-regulatory guidance. Contract pharmacy is not anywhere in the statute, and guidance doesn't have the same force and effect of it does not bind parties the same way that a regulation does. So I'll put that sort of out there in terms of the legal matter, which I know is being actively litigated. We don't think that the contract pharmacy guidance can impose binding obligations on manufacturers. But as a policy matter, I want to point out that there has been substantial growth in the contract pharmacy program. And I know people talk about access and how this is helping access, and I'm glad to know that, people feel that that is the only way to look at the issue. I mean, at least that we're looking at in terms of helping patients, but we also have to look at whether patients are even receiving the discounts at these contract pharmacies. According to GAO, less than half of the hospitals that they surveyed actually provided 340B discounts to low-income patients, low-income uninsured patients, even at their contract pharmacies. So I think, it's evidence like this that's really making us question, the role of contract pharmacies in the program, and whether the program is really operating the way Congress intended.
Okay, and thanks for that summary. I think that's a good jumping off point. And Ted, I just wanted to offer you an opportunity to add on to that, and also just kind of point out that within kind of the hospital community, there are different, opinions on this issue, just because, like for-profit hospitals, for example, aren't eligible for 340B discounts. So I think there is, some diversity of opinion within the provider community. So just wanted to offer an opportunity for you to kind of build on, I think, what Sylvia was saying. If you're,
I'll do this and I'll connect it up to something that Bob said. Let me give you some stats. 10 years ago, if you look at contract pharmacies, there were 1,300. Today, there are 30,000 locations. And one of the craziest things is that, aside from the fact, and I totally understand what Sherry is saying, especially community health centers, but this contract pharmacy is largely being driven by the DSH hospital side of it. And, here's the problem. The PBMs. I never thought we'd talk about the worlds colliding of PBMs and basically 340B, but it's happened. Because if you look at the top 3 PBMs that control, 80% of the prescription drug flow, so CVS, Express Scripts, and Optum Rx, they have 142 specialty locations right now that serve as contract pharmacies. You say, well, that's nothing out of the 30,000. That's less than 0.5%. The problem is that if you look at the number of relationships that they have, their number of relationships compared to the relationships of all contract pharmacies is close to 20%. So these PBMs aren't stupid. They know how to make money, and they've basically found a way to get into the 340B program. So why do we have a problem with this? Why is there a problem in terms of this proliferation, especially on the hospital side? Because hospitals make a ton of money off of drugs. We just released a report that was released yesterday that we commissioned that shows that 340B hospitals, the one that we're reporting, basically make 3.8 times median average in terms of basically what they acquire the drug at 340B prices and basically how they're compensated by commercial insurers. They make a lot of money. There's huge markups on these drugs. What does that mean? Go back to Bob's point. They look at practices like independent community oncology practices, and they want to basically take them over, acquire them, which has happened over the last 10 years like crazy. And because they make so much money on these drugs. So when they acquire a practice and they bring the practice in, if you think of an average oncologist, depending on what type of patients, what type of cancer he or she are treating, they may account for $5 million worth of drugs. When you say the average discount on these 340B can be 50%, you're talking about an oncologist being worth $2.5 million just in drugs, just in 340B drugs, not in facility fees or anything else. So it has been a major, as we told the FTC in a Zoom 2 weeks ago, this is one of the major contributors for consolidation, which is something that they're studying.
Excellent. I think that obviously we did, touch on this a little bit in the Bob Q&A, but I think the structure of this program is, somewhat unusual that, the benefits to providers who are, in serving these low-income patients is, an overall markup. Like that is the structure of the program as it was designed. So yes, certainly those markups are happening, but that's also kind of the structure of the program too. And we appreciate you bringing up the quantification of that. I think, Maureen, is there anything you'd like to add on that issue? Just because I know I have other issues that we'd like to get to as well, but just wanted to offer you a quick opportunity to speak on that if you wanted to.
Well, I just wanted to, I really appreciate your explanation because you're absolutely right. That is sort of how the program works. That's the whole point. It's basically, there is a benefit that comes as a result of these discounts that the providers use and they put right back into Care for People. And there's so much research out there about how much hospitals are providing, as I said earlier, in terms of care to people with low incomes, people with disabilities, people with chronic conditions. So it is actually very clear to see how much benefit 340B is offering through hospitals and through the grantees.
Okay, excellent. And there's one more question I wanted to follow up with you on, Maureen, about from Bob's panel about just kind of the potential impact of the Supreme Court decision, like how your members thinking about that in terms of kind of their futures with this program.
So the Part B issue and the reduced reimbursement to some of the 340B hospitals, many 340B hospitals, but not all, is definitely a big concern. It's a loss of about $1.6 billion a year, and so that is revenue that they are not necessarily able to put back into services. But I think one of the big concerns is the way that this has been done by Medicare is they are taking that discount that's offered by the drug companies. So they're taking it for the Medicare program and then they're increasing reimbursement to non-340B providers as well with that money. So it's really what they're doing is they're taking something that Congress said, this is a benefit that we want to give to safety net hospitals so they can improve care. And we're taking it and we're going to redistribute it to providers that don't meet the criteria that you have to meet to get into 340B, like treating a lot of low income people, a lot of Medicaid people, and that type of thing. So it's a real concern for us in terms of how that revenue is being used. And we think it should not be something that's going into just increasing payments generally to Medicare providers.
Right. I think that's an interesting issue to point out too, that particularly with this reimbursement issue at the Supreme Court, it's zero sum. So if, one provider gets, a certain discount or certain reimbursement rate, kind of that affects everyone else too. So yes, certainly will be something to watch. Visharia, I wanted to just give you an opportunity to comment on an issue from earlier as well on the Trump administration's policy targeting insulin and EpiPen discounts at community health centers. The Biden administration did decide to roll that policy back, but I just wanted to give you a chance to kind of talk about how you view that policy.
Yeah, I mean, just to set the stage a little bit, when the Trump administration issued that executive order was in the middle of COVID. Our health centers are on the front lines without reimbursement for a lot of the services they are providing, but just because they have a duty to their patients as well as their communities. So from our perspective, we believe that he mischaracterized, or the executive order mischaracterized the health center program, our mission, and also our integrity. We provide services, but we do not set the cost of insulin. We do not set the price for the EpiPen. And we do what we can to make sure that our patients who can't afford it can afford it. But also, besides just access to the medication, we provide the services to help them manage diabetes and other chronic diseases. So we were very happy to see the Biden administration take swift action to rescind the regulation. The final rule that is rescinding the final rule should be coming out shortly. But our health center mission is to reinvest every penny back into care. So we believe that it targeted the wrong group or targeted the wrong providers in general, as 340B providers value the program and value our patients. But really, in general, the timing of it was just very poor. I mean, our health centers were kind of deflated when they saw that. It's hard to have morale and keep up the good fight when you're being mischaracterized as taking advantage of a program that health centers value and prioritize, but also help us do our great work every day. So we're happy to see the final rule being rescinded, even though there are questions around as long as the Trump executive order still exists. The Biden administration has not revoked the executive order. So it's a question of, will this come back again in a different way? But we have faith in the Biden administration that they are very supportive of community health centers. They're supportive of the 340B program. So we're hoping that this is a threat that we have dodged completely and can take off the table.
Excellent. Thanks so much for that perspective. And I think we're, still in the middle of COVID at this point. But Sylvia, I wanted to talk to you a little bit more in detail about one aspect of the contract pharmacy activity that we haven't gotten into that deeply yet. And obviously, different, drug makers have made different decisions, but some drug makers are requesting more data to provide discounts to contract pharmacies. I know there's, concerns about, it's kind of a wonky term, but duplicate discounts. Like how are your members thinking about concerns about what data is available and kind of how to make sure the program, is being used as it should be?
Well, I guess I should first just clarify what a duplicate discount is, right? And it's important to know, Congress was really clear when they created the 340B program. They knew they were giving very generous, they knew that manufacturers were going to be giving very steep discounts. And they wanted to make sure that those discounts only went to, specified covered entities. There are 15 covered entities listed in the statute. But in exchange, covered entities also were required to ensure that they were complying with two very important provisions in the 340B law, and that's the prohibition against duplicate discount, and that's when a manufacturer would have to pay both a Medicaid rebate and a 340B discount on the same drug. And also covered entities are prohibited from committing diversion, which is when a drug is, transferred or otherwise sold to someone who's not a patient of the covered entity. Those are very important safeguards. But what we've seen, and the OIG and GAO and others have reported, and even HRSA audits have reported, there is a significant amount of duplicate discounting going on. And there's a lack sometimes as well, I think, of, on HRSA's behalf, they haven't done a great job in terms of issuing any guidance to prevent duplicate discounts on Medicaid managed care claims. And as we know, growing numbers of beneficiaries in Medicaid are now enrolled in Medicaid managed care plans. So it's kind of, surprising, I would say at the least, to know that there is no prevention, mechanism in place. HRSA hasn't set one up for, or CMS has not set one up yet, really to effectively prevent duplicate discounts with Medicaid managed care claims. Our companies have asked for claims data in some cases. Again, I probably would just refer you to take a look at the way they've done it, because each of them have done it differently. So it's a little difficult to kind of have a generalized way of talking about that. But yes, they are looking for increased transparency. And I think that's really an important theme. You've heard it on the panel today, but a lot of that is, it is a black box. Manufacturers do not know a lot of the information that they need in order to prevent a duplicate discount, and they need that type of data to do so.
Right. Thanks so much for kind of giving us an explanation of that issue as well. This program is so complex. And Ted, I just wanted to loop back to an issue that I think we were talking about a little bit earlier, just kind of about the idea that the reimbursement in Medicare for like 340B covered entities, is a zero sum, I don't know, game isn't the right word, but it's just, a zero sum process where, if, one provider has their payment amounts adjusted, then that kind of affects everybody else too. So I was curious to hear, how that's played out for your members.
Well, it doesn't affect us because we're not basically tied on the HOPS fee schedule. But I will tell you, we did an analysis when they first came out, that the administration, HHS, first came out and proposed the ASP minus 22.5%. We actually had Avalier Health look at basically how that would be readjusted. And the interesting thing about it, Rachel, is because it was putting money back into not just for-profit hospitals, it was putting money back into non-for-profit hospitals, that in most hospitals, we're actually making more. Who is getting hurt the most are the biggest 340B users. So that's the way that works. And I'm sure if you ran the numbers again, you would see exactly the same thing. The other thing I just want to come back to, and one thing that you said, that Rachel, in terms of the program and sort of this idea that hospitals can mark up drugs and basically off of 340B. You know, the problem here is, first of all, as the report that came out yesterday, the markup is not only off of that 340B discounted price, but it's twice the markup, median markup of just looking at WAC. And here's the problem with that. Remember that an individual who's part of that's an employer plan, that's an Aetna plan or a United plan, whatever the case may be, they're paying more and more. As you know, employers and in commercial insurance, more is being cost shifted onto the patient. So the problem is the patient is the one paying that inflated price that comes from the markup of the hospital. So we've got to keep that in mind, that it's not just that the hospital has the ability, the 340B DSH hospital, to basically mark up these drugs and then plow it into other areas, but basically it's affecting the person who comes in. So it's no reason that you have more and more Americans complaining costs, because you take a drug that's expensive from the manufacturer to begin with, and then you multiply it by the hospital, and it's the cost to that individual, their copay, their insurance that they're paying, their part that they're paying, that's what they get hit with.
So I did just want to talk a little bit about this transparency issue. You know, it's come up several times in this panel already, and we do have an audience question about that. And I think it's important to remember that this program is unique, because in a lot of other kind of parts of kind of the drug supply chain, there's a rebate system where, you know, a provider might pay full price, and then kind of the back end kind of evening out of what price should be paid kind of happens later. But in this program, it is a discount. So it's almost trying to track money that wasn't spent somewhere else. So I just wanted to offer an opportunity for Visharia or Maureen to talk about kind of how to track the absence of money being spent somewhere else, just because on a balance sheet that, it presents some challenges, but it also, presents some questions if, these discounts, are coming from drug makers, the transparency. So I just wanted to offer you an opportunity to explain kind of what transparency measures your members have been looking at.
I'm happy to start. And I would go back to sort of what I said earlier, which is, again, hospitals report every dime that comes in, and they report every dime that goes out. So you can look at a Medicare cost report and you can see, what are hospitals doing in terms of uncompensated care? What are their spending patterns for outpatient? What are their spending patterns for inpatient? You can look at any of the public IRS 990 forms and look there. How much money are they spending on their community? How much money are they spending for charity care, and other types of uncompensated care? So a lot of that is there, and they are able to track and have a sense of how much they are saving as a result of 340B, because what they do is they compare it to what they would have spent otherwise. So hospitals typically buy their drugs through a group purchase organization that can negotiate discounts. And so they compare what was our 340B price compared to what our GPO price would have been. And so they have a sense of that there. But I'm wondering if I could just address another point that came up earlier. One thing, Ted had mentioned about, the potential for 340B to increase prices. And I have heard that, but there's been published research in the Journal for the American Medical Association that absolutely refutes that and points out that 340B actually reduces the prices of drugs, even for drugs outside of the 340B program. So I think that's a really important point when looking at 340B. It does that because if you are a drug that's part of 340B program and you raise the price higher than the rate of inflation, that means the percentage discount that you give gets higher. And the more you raise the price, the higher that discount becomes. And so it acts as a way to try to keep costs down. And I also wanted to mention, it was brought up that companies in this contract pharmacy issue are collecting data around claims, and Medicaid was brought up, but actually most of the data that they're looking to collect relates to commercial payers, and they're trying to collect data. Drug companies give a voluntary rebate. They're not required to do this under any law, to give a rebate to PBMs. PBMs. And so what they were trying to do is collect data there so that they don't also have to give a discount because they've already given a rebate to the PBM, which is really well outside of anything to do with 340B. And we just really don't think that 340B claims should be treated differently that way.
All right. Well, thanks for that explanation. I think we are approaching the end of our time together. So I just wanted to, offer each of you an opportunity to talk about a potential solution that you'd like to see from the Biden administration on this issue, because we've talked a lot about kind of the different problems in the program. There's a lot of complexity that's going to be worked out in the next couple of years, or maybe not. It'll still go on in the next couple of years, as we've seen over the course of the program. I guess, Sylvia or Visharia, would you like to start with kind of a solution that you might like to see from the Biden administration on 340B?
Yeah, I could start if that's okay, Sylvia. I do want to just say that health centers make a good faith effort to comply with the 340B program, and that's something that we have definitely prided ourselves on. We are compliant with data requests. We want to work with the manufacturers if they would like to audit. And that is what NAC has always told our health centers as well, as as long as we continue to make a good faith effort to work with manufacturers, to work with the government to comply with the program, then the integrity should stay intact. And that's really important for us. A solution is definitely to get the ADR process up and running. As you know, we have a lawsuit against the administration, predates them, but there was a lawsuit to get the ADR process running. Now the regulation has been issued. However, our petition on behalf of 225 health centers has yet to have a ADR panel appointed to our petition, which would also address the contract pharmacy issue and have the determination on if that is a part of the 340B program or interpretation of the statute. So number one thing for us, I think, would definitely be to have an equitable process with the ADR rule and have that up and running so that we can have our day and to have our health centers claims heard. I think second is just to continue the conversation of how we can strengthen the 340B program. I feel like we've been kind of in a very shaky place. And I think for our health centers, we would really like to have more stability, so our health centers don't feel like the rug is going to be pulled under their feet with one change in this rule or one change in this courtroom. So that is really important for us, stability, but also this ADR process.
Thanks so much. Sylvia, would you like to go next?
Yeah, and Visharia hit on some really good points, and we do think that many of the grantees are operating as true safety net providers as the program was intended. But we don't see the same set of rules, obviously, applying to hospitals under the program. And obviously, grantees have their own grant requirements. But we think that there are, steps that could be taken to increase the transparency and accountability in this program. There was some federal legislation that had been introduced a couple of years ago that would have required or imposed reporting requirements on certain private hospitals that operate in the 340B program. And it would require them really to report data in a way, not only by the hospital, but also by a child site, so that we could really see, how the discounts are being used, how much reimbursement each part of the hospital is getting from payers, and what the acquisition costs then are. Also, I think it's important to keep in mind the patient, right? We know that right now we don't have a requirement that the discounts help the patients, and people have pointed that out in the chat very helpfully. But still, you have to think this is a safety net program. Shouldn't it be helping patients with their drug costs? And I think that the legislation would have also required more reporting on the types of patients that are seen by 340B providers, and the kind of insurance status they have, and what payer covers their costs. So those are the kinds of transparency requirements we'd like to see. But overall, just a more honest conversation about what's really happening in the program, and to really be able to look at more reasonable and responsible reforms that are really patient-centered. We really want to put the patient back in this program.
All right, we'll have a couple, lightning round here with Ted. Would you like to add anything else?
Yeah, I think that I'll echo what Sylvia and Visharia just said. I think the federal grantees are held to a level of accountability and transparency, and regardless of any reports, any IRS reports or anything else like that, the hospitals, the dish hospitals are a black hole. And I think what we need is legislation of transparency and accountability. So transparency into basically where the discounts are being used, and accountability that those patients in need are receiving. I think, frankly, what should happen in the hospital side is the discount should go to the patients. The discount should go to the patients in need. That is something that we would like to see happening as well, too. I think that's very, very, very important, because there are patients in need that can't afford their drugs, especially when they're marked up by the hospital. I wasn't talking about 340B adding to the price of the drugs before. I was talking about literally the hospitals marking up the drugs. Read the Modal Advisors report that's on the CO website, and it's startling. So I think that's what we need: accountability and transparency, Rachel. And really, the discount should really go to the benefit of the patient. We should make that there's no patient at all that's not getting their discounts. And by the way, I shouldn't have to read another story like I've read about a number of big hospitals that aggressively debt collected. And then you look up and you see, are they a 340B hospital? And they're a 340B hospital. And we're hearing more and more stories. We see, as you know, in the press, more stories about debt collections from hospitals. And that shouldn't be the case with 340B hospitals.
All right. Thanks so much, Ted. I appreciate it. And
Yeah,
Maureen, would you
thanks
like to
for having
close this out?
Contract pharmacy is really the biggest issue that I think is facing 340B right now. And I think it's time for HHS to impose civil money penalties on the manufacturers that are engaging in this behavior. It's a really big problem, especially in the world of diabetes, where we see the top manufacturers of diabetes that are subject to the highest penalties under 340B are the ones that are participating in refusing the discounts under contract pharmacy. So we really think it's time for HHS to move forward.
Right. Thanks to all of you for joining us today. I've certainly learned a lot, and I hope our audience members have too. Thanks so much for our featured speakers. And for all of you still out there, thanks for asking great questions. Apologies we didn't get to all of them, but certainly it's great, food for thought and for our coverage moving forward. A reminder that our next virtual event, The Evolving Landscape for Biosimilars, will be taking place Thursday, September 30th from 1 to 2 p.m. And Stats Ed Silverman will convene a discussion on what it will take to create a functioning biosimilar market in the U.S. More information and registration details to join us can be found on our website. And until then,